Okay, good afternoon to both of you, Annie and Jenilyn. We'll go ahead and continue in the interest of time. So yesterday we were talking about stroke, and what I wanted to do today is to continue on our discussions on stroke. So I'm just going to rapidly change the slides over here, and I beg your pardon, um, so that we get to where we stopped yesterday. Okay. So whenever we have a patient with stroke, it's important that we adhere to time elements because there's going to be a very important time sequencing that has to be followed in order to save brain tissue. And so this is a busy slide, and we're going to go through it one by one. And the first ones that are going to be included in the time-sensitive interventions are going to be this. And they include actions that has to be done in the first 10 minutes, as well as actions 15 minutes, 25 minutes, 45 minutes, and at 60 minutes. Early intervention when a stroke is suspected is obviously important to optimize the outcomes neurologically. And so after the patient enters the emergency department, what usually is done is that an hour clock should be started so that all staff members are aware of when each time sensitive intervention should be performed. So the recommendations of the American Heart Association dictates that all emergency departments should have a clock or a stopwatch that individuals in the team can activate at time zero. So this is the time from which all emergency interventions will start. So the American Heart Association and the American Stroke Association developed the 60-minute or less stroke protocol that all healthcare facilities should follow. And this includes the following. On the first 10 minutes, the patient should be seen right away by the emergency room physician for an initial assessment. And within 15 minutes, the patient should be seen by the stroke team. And as you could see at 15 minutes, at 25 minutes, a non-contrast CT scan should be performed. And at 45 minutes, there's the CT scan results should be available so that a decision can be made for the treatment. Now, the reason why the CT scan is very important is we want to make sure that what we're seeing is a stroke, number one, and the more important one is if it is ischemic stroke or hemorrhagic stroke, because ischemic stroke and hemorrhagic strokes are treated differently. So at 60 minutes, if the patient is going to have an ischemic stroke, there has got to be initiation of fibrinolytic therapy or an alteplase therapy within 3 hours of the stroke symptoms, unless, of course, there are contraindications. So that's the action plan as far as the presentation of a patient in the emergency department. So what are some of the clinical manifestations that we are going to see in patients who have stroke? Stroke can cause a very wide variety of neurological deficits. And again, as we had discussed yesterday, it depends on the location of the lesion of the stroke, the size or the area of inadequate tissue perfusion, and of course, how much collateral circulation the patient has. But generally, the clinical manifestations includes motor loss, as well as communication loss, perceptual disturbances, and impairment of cognitive and psychological effects. So let's take a look at the motor loss. We'll talk about hemiplegia, which is going to be a paralysis of one side of the body, and hemiparesis, which is going to be weakness in one side of the body. So those are going to be the major manifestations as far as motor loss. But we could also have flaccid paralysis. And this could, of course, change and progress into spasticity in the later stages. Now, in addition to that, there could be communication loss. And we all know that one of the presenting signs of a stroke is going to be dysarthria, which is a difficulty in speaking. Or it could also be dysphagia, which is impairment of speech. And one thing that I need to emphasize is that whenever you have a patient with dysphagia, which is difficulty of speech, you might also have aphasia, which is going to be loss of speech. And then the last one, as far as communication loss is concerned, is apraxia. And apraxia is something wherein the patient is not able to perform something that they learned before. So it's kind of weird because patients might not even know how to use a toothbrush anymore. So that is what's going to be one of the characteristics of the communication loss that usually happens in patients with stroke. And then we also have perceptual disturbances and sensory loss. When we say visual perceptual dysfunctions, well, this could include, for example, a loss of half of the visual field. So that if, for example, I'm just going to illustrate it over here. If this were the eyes of the patient, we might have visual loss on one side of the visual field. And this is what's called hemianopia. And there's differences or different kinds of hemianopia. While one could be homonymous hemianopia, which is half on the same side, but we could also have a situation wherein it's heteronymous, and that would be something like this. There's visual field right over here, loss over here, and then the other one is right over here. So they're on opposite side. And this is what is known as heteronymous hemianopsia. This one is homonymous. Homonymous. All right, there's also other kinds of hemianopia, like only the upper part, that's superior or inferior. But the most common ones are the homonymous hemianopia. The other perceptual disturbances that might occur are going to be disturbances in visual spatial relationships, meaning to say that patients will have difficulty perceiving the relation of two or more objects. And this is usually very common in right hemispheric damage. And lastly, sensory losses like slight impairment of touch, or sometimes the person might have difficulty in interpreting visual as well as tactile and auditory stimuli. All those are going to be signs that the patient might have a stroke. Then there's going to be impairment of cognitive and psychological effects. We all know that particularly in the frontal lobe, learning capacity and memory is going to be altered if that's going to be involved. And then sometimes your intellectual functions are also going to be impaired. Depression is a very common psychological problem that accompanies stroke, and sometimes it might be manifested not only in having emotional lability, but also sometimes patients become frustrated, they might become hostile, or sometimes they lack cooperation. And all these things are all part of the spectrum of the clinical manifestations of stroke. Now, the American Heart Association and the National Stroke Association recommends that we have to have a specific stroke assessment tool to evaluate patients suspected of having a stroke. And there are two common stroke assessments that are utilized here in the United States, and they include the Cincinnati Pre-Hospital Stroke Scale, which is demonstrated or illustrated in the slide over here. And the other one is the NIHH, the National Institutes of Health Stroke Scale, or NIHSS. So these are going to be utilized in order to determine whether or not the patient has a stroke. Okay, so the first one is going to be your Cincinnati Pre-Hospital Scale. And the Cincinnati Pre-Hospital Scale evaluates an individual on 3 areas: face, arm, and speech. So as far as facial droop is concerned, the normal is that both sides of the face move equally. Now, abnormal is going to be when one side of the face doesn't move at all. So have the patients show the teeth or smile in order to assess this. The other one is arm drift. Now, the patient should be asked to close their eyes, and hold their arms like they're holding a pizza. And this should be for a period of 10 seconds. And normally, both arms should move equally or not at all. But if a stroke is suspected, one arm might drift compared with the other, or they might pronate, something like this. Okay, their hands move forward like this instead of keeping their hands supinated, as I am illustrating. And lastly, they're going to have the patient say, "You can't teach an old dog new tricks," or similar phrases like that. Normally, the patient uses correct words with no slurring, but in people who have suspected of having a stroke, the patient might use slurred or even inappropriate words, or worse yet, they might be mute. So this is going to be a rapid way of assessing the patient for the presence of stroke. Now, the interpretation, if any one of these 3 signs is abnormal, the probability of stroke is going to be 72%. So that's going to be a very rapid way of assessing the presence of stroke. But we in the hospital use the NIHSS scale. That's the National Institutes of Health Stroke Scale, or NIHSS. I don't know if you all were required to do this. It's a web-based course. All nurses are actually required by all hospitals to take this course. So once you get employment, you probably will be required to do so. And it's a little bit, it's a hard course. It's not simple. But anyway, it was developed to help nurses and doctors objectively identify the severity of ischemic stroke. And this involves assessing 15 specific areas for abnormalities or disabilities. So the modified version, by the way, only assesses, as illustrated over here, only assesses 11 specific areas, but the original one was 15. All right, so what is going to be the procedure, or what is the value of the NIH stroke scale? Well, as I said again, it's going to provide a quantitative measure or a number wherein we could determine the severity of the stroke. Right? So it evaluates the severity of the stroke. It also helps determine the appropriate treatment, and it also predicts patient outcomes. So the scale is made up of 11 elements again, and the score for each ability is going to be numbered from 0 to 4. And 0 being normal functioning and 4 being completely impaired. Okay? So The scoring is the one that is going to be important. And the scoring is going to be this one. If it is 0, then that means to say that there is no stroke symptoms. But from 24 to 42, that would indicate that there is severity or severe stroke that is present. As illustrated over here, 1 would indicate or suggest that there's minor stroke, and 21 to 42 indicates that it is a severe stroke. Okay, so that is the NIHSS scale. This is most likely to be more something that would come out in the NCLEX rather than the Cincinnati scale, the NIHSS. So remember that 0 is no stroke symptoms, and anywhere from 1 to 42 would indicate that the stroke is present, and the higher the number, the greater or the more severe the stroke is. All right, let's go to the next, a poll. So I think this one. Nope. There you go. Okay, so let's take a look at this. A patient in the ER is diagnosed with intracerebral hemorrhage. So you remember there are 2 types of stroke. One is called ischemic stroke, and the other one is called a hemorrhagic stroke. So when you have a patient with hemorrhagic stroke, the patient's speech is slurring and difficult to understand. That's going to be part of the symptom of stroke. So we will not be this is not going to be the most important thing that you will communicate to the physician, because this is one of the symptoms. And then the patient's latest BP reading is 140/90. Well, that might be something that would be significant. The patient takes a diuretic for hypertension. It's not very important. But look at this. The patient has atrial fibrillation and takes warfarin or Coumadin. Now, the patient has a hemorrhagic stroke, and therefore, this is going to be the most likely situation that we need to reverse right away with vitamin K in order to prevent further bleeding. So the correct answer here is letter D, all right? Because the patient is taking warfarin. Very good. So a stroke of 40 is going to be obviously a severe stroke. Anywhere from 21 to 42 is going to be a severe stroke symptoms. So great. All right. So what are the additional assessment findings or diagnostics, I should say, that should be implemented in patients that are suspected of having a stroke? So any patient with neurological deficits needs a careful history, which we had already talked about, as well as a complete physical examination, but also we have to have diagnostics in order to complement or supplement those findings that we found on neurological examination. So those would include your capillary glucose, because you remember that hypoglycemia actually can mimic the signs and symptoms of stroke. So sometimes we don't know if the patient is really having a stroke or just having a hypoglycemic attack. And that is why capillary glucose has got to be obtained right away. The other thing is CT scan. Uh, we know that a CT scan is always done in order to determine what kind of stroke has occurred. Is it an ischemic stroke or is it an intracerebral hemorrhage? Because if it's an intracerebral hemorrhage, the intervention is going to have to be different, like surgery. But if it's an ischemic stroke, the intervention would be to give a fibrinolytic agent like alteplase or a thrombolytic agent to dissolve the blood clot. All right. So that's why CT scan is very important. PET scan also, this is going to measure cerebral metabolism. It's not going to be as critical to be done during the first hours, but that they could be ordered later on. MRI also could show hemorrhage, as well as cerebral angiography. And this is going to help determine the specific cause of the stroke. And lastly, lumbar puncture. So what is the value of having a lumbar puncture? Pressure is usually normal, and the cerebrospinal fluid is usually clear if the pathology is that there's going to be an ischemic stroke, or the pathology is, let's say, TIA. However, grossly bloody fluid would suggest that the patient is suffering from cerebral hemorrhage or bleeding. And that is the reason why lumbar puncture could be very useful in these cases. The other things that you see on the right side, like your transcranial Doppler ultrasonography, as well as EEG and a skull X-ray, are things that might be utilized, but not as critical as these things that we had mentioned right over here, okay? And of course, ECG and echocardiography in order to find out any, to rule out any cardiac origin, like for example, that there might have been an emboli, which would have caused the stroke. Having done your assessment then, what are some of the interventions or the medical management that you need to expect in these patients? So whenever patients have experienced TIA or stroke, they're going to have medical management for secondary prevention. And the first one that is going to be common is the recombinant tissue plasminogen activator, which is going to be prescribed unless it's contraindicated. And of course, this must be given within the first 3 hours. So TPA is only given for ischemic strokes only. Okay. Remember that this is going to lyse or dissolve any existing blood clots, and that is the reason why these is going to be used only for ischemic strokes. So again, how does it work? It dissolves the clot within the blood vessel by activating the protein that causes lysis or dissolving of the blood clot. But remember, it must be given within 3 hours from the onset of stroke symptoms. It can be given 3 to 4.5 hours after onset if certain criteria is met. But generally, it should be within 3 hours. Okay. So in order for the patient to receive TPA, the following has to be done. The CT of the head should be negative for hemorrhage, and that the labs should be within normal limits, which includes your glucose as well as your INR and blood coagulation profiles. The BP should be controlled. The systolic blood pressure should be less than 185, and the diastolic blood pressure should be less than 110. And then, of course, the glucose should be controlled. There should not be a hypoglycemia or hyperglycemia, because increases of glucose will increase the risk of hemorrhage. And that's the reason why that is going to be critical. And then, of course, they must not be receiving heparin or other types of anticoagulants. The major nursing role, as far as the administration of TPA or tissue plasminogen activator, is to monitor for bleeding. So that is the most important thing that a nurse must do, or intervention that a nurse must do in patients who are receiving TPA. Now, in your hospital rotations, have you had the opportunity to see a patient receiving a TPA? You probably have not if you did not go to the emergency room. But this is very intensive. Whenever we receive a patient that requires TPA, we have to make sure that we monitor for bleeding. And even after we had administered the medication, the neurological checks has to be done around the clock. And blood pressure medications usually are given in order to control hypertension. And in addition to checking vital signs frequently, the patient's blood glucose and labs are going to be monitored as often as possible. And then, of course, because of this tissue plasminogen activator, or TPA, or alteplase, is going to cause fibrinolysis, it is important then that we need to avoid anything that might cause bleeding. So what might cause bleeding? You cannot you cannot give intramuscular injections, no intramuscular injections, no venipunctures after you have given this drug for at least 24 hours. That is the reason why before we give this TPA, we need to at least, the more IVs the patient has, the better. So usually we have a minimum of 3 IV sites that we have, one that we could use to draw blood so that we do not have to do venipuncture after the medication has been given. Okay. What else? All right. So what are some of the absolute exclusions as far as TPA is concerned? Well, the patient should not have had a head trauma in the last 3 months, because if they have had trauma in the last 3 months, there's a possibility that we might rupture any existing clots that's trying to prevent any bleeding. If the patient has had a stroke in the last 3 months, if the patient has had a subarachnoid hemorrhage, a previous intracranial hemorrhage, active bleeding, heparin in the last 2 days, an elevated INR hypoglycemia, a very large brain infarct, and platelets that are less than 100,000 per cubic millimeter. So you don't need to remember this, but one of the clues that is going to be important for you to take into consideration is we are giving a medication that will dissolve existing blood clots. So think about that. And therefore, anytime the coagulation profile of the patient is abnormal, like elevated INR and platelets that are low, we certainly are not going to give this medication. All right. So that's the important thing. There are some relative exclusions, but that's not important for you to remember. And lastly, who are included or who should receive this drug? Well, if the symptom onset within the last 3 hours is noted, meaning to say that it's not longer than 3 hours, then these patients should receive a TPA. If they're 18 years or older, and then, of course, if the patient has ischemic stroke or the blood pressure is less than 185 systolic and less 110 diastolic. So those are the inclusion criteria for the administration of TPA. So there are several nursing interventions before you give TPA or alteplase or activase. And the first thing is, of course, before treatment, the stroke onset must be confirmed. It must be less than 3 hours before the drug administration. And then, of course, we want to make sure that we confirm the patient's eligibility, which we had already discussed earlier. And you need to draw CBCs. You need to order a head CT scan. As you have noted in that protocol, we have to have a CT scan within 30 to 45 minutes, as well as your APTT, glucose ECG, and a pregnancy test. All right, that is important. Obviously, that's for all females. And then, of course, blood pressure and urine check has to be done every 15 minutes. And we want to keep the systolic blood pressure at less than 185 or a diastolic blood pressure of less than 110 millimeters of mercury. Establish 2 to 3 IV lines. That's the minimum. I used to work in emergency room, and we used to start at least 3 or 4 IV lines. The more, the better, because you don't ever know if one of them is going to blow or infiltrate. And therefore, the reason why you want to do that is because after giving the drug, you can no longer insert an IV for at least 24 hours. And then, of course, we want to make sure that we obtain an actual weight of the patient. And lastly, to connect them to cardiac monitoring in order to make sure that there are no cardiac complications that is going to occur. All right, so during the administration of the drug, there are important things that we need to do. And these includes your neuro assessment. Again, you need to do neuro assessment because of the fact that there might be a danger of having a bleed in the brain itself as a result of your thrombolytic agent. So that's the reason why it is important that you perform a neurological assessment every 15 minutes. Then, due to the risk of bleeding, you need to make sure that you check for bleeding. Any signs of bleeding has got to be reported right away to the physician, and monitor for signs of increased intracranial pressure, or ICH, or intracranial hemorrhage. And then, of course, there might be instances where individuals might become allergic to the alteplase or the streptokinase. And so oral-lingual angioedema, or swelling of the mouth and the tongue, are very frank signs that the patient is having an allergic reaction. And then, of course, we discontinue this medication if the patient develops a headache, because it might be possible that the patient is developing a hemorrhage intracranially, or if the patient develops acute hypertension, nausea and vomiting, and a deterioration or worsening of their neurological exam. All right, so the infusion in itself is usually completed within 1 hour. So the interventions continue after the treatment has been given. And so what we do after the therapy is, of course, we want to make sure that the patient is going to be admitted to an ICU. And we continue to monitor the vital signs every 15 minutes for the next 2 hours, and every 30 minutes for 6 hours, and then every 1 hour for at least 16 hours. So as you could see, this is a labor-intensive patient. If you get a patient post-TPA, we usually assign only one nurse to this individual because it takes a lot of time in order to deal with all the things that you have to do for this patient. All right, so we want to make sure that we continue the vital signs, in particular the blood pressure, because we don't want the blood pressure to go high. We, of course, continue to monitor for bleeding, and no invasive catheters. So I mentioned that there should be no IV or IV sticks that has to be done, or intramuscular injections. Also, there should be no insertion of any tubes, like, for example, nasogastric tube or maybe a Foley catheter. That cannot be done until after 24 hours later. And then we usually are going to send the patient for a follow-up CT scan or MRI after we have completed the treatment for 24 hours. And then this is so to determine whether or not it's safe to start them on anticoagulants or antiplatelet agents. Very good. So the answer is letter C. You remember that TPA dissolves the blood clot, causing the blockage in the stroke by activating an enzyme that causes the dissolution or the dissolving of the blood clot. It should be given within 3 hours after the onset of stroke symptoms. And of course, it is not used for hemorrhagic stroke. It's only used for ischemic stroke. Okay, so remember that we give TPA for anybody who has got an ischemic stroke, right? So we would not give it if the blood pressure is above 185 over 110. So this would be a contraindication. And then, of course, a patient who received heparin 24 hours ago, this is going to, or any anticoagulants, if the patient has recently taken it within the past 24 hours, then this is not going to be a candidate for TPA. So the correct answers are B and D. Remember that patients who are highly suspicious of a stroke are going to have to be candidates for TPA. Okay, very good. So, antiplatelet agents like warfarin therapy, this is going to be correct. Aspirin twice per day. Well, this is not going to be correct because we are only giving preventive measures. So, it usually is going to be a once a day. And letter C, controlling hypertension or diabetes is important. So, this is correct. And monitoring for signs and symptoms of recurrence is also correct. Excellent. All right, so let's now go to the medical management, further medical management other than TPA for patients who have had stroke. What are some of the other medications that we can anticipate for the patient to be receiving? Well, furosemide or diuretics are usually given in patients who have stroke in order to decrease the possibility of an increase intracranial pressure. And the danger of increased intracranial pressure is going to be herniation. And so herniation is when if you have if you have the brain here, and this is the spinal cord. We all know that the brain is enclosed in a rigid structure called the skull. So when patients who have brain injury, sometimes because of the inflammation that occurs in the brain, there's going to be excessive pressure. And so when pressure collects over here and it can no longer expand, what it has to look for is a weak area. And this weak area is the foramen ovale, where the spinal cord is located. And so parts of the brain will start coming down into the base of the brain, which therefore would cause death of a patient. This is what is known as truncal herniation. And this is the danger of whenever we have injury in the brain and there's collection of pressure that cannot be vented. And so that's the reason why furosemide and mannitol, which is an osmotic diuretic, are going to be used in order to prevent or decrease cerebral edema. Phosphophenitoin, this is going to be a drug like phenytoin, and this is going to decrease the possibility of seizures. And then, of course, benzodiazepine are also going to be useful in the management of patients with stroke because this is going to be a drug that could reduce spasms of the skeletal muscles. And that is why it's included over here. All right, so the additional medical management might be aspirin, but 160 to 325 milligrams once a day, high-dose statin like atorvastatin, and anticoagulation this is going to be particularly important when the patient has had an emboli as a result of atrial fibrillation. So this is not recommended during the first 48 hours after an acute ischemic stroke, but warfarin can be started for small or moderate sized infarct after an MRI has been done in the 24-hour mark. All right, I mentioned something about surgical interventions earlier, and certainly patients who have had a stroke can undergo surgical interventions. And one such surgical intervention is what is known as endovascular thrombectomy. And that is when they go into the blood vessel that is going to be occluded and remove the thrombus and therefore reestablish the blood flow. And this is going to be what is known as endovascular thrombectomy. The other surgical procedures might be a bypass graft. This is going to be a very uncommon procedure. But for hemorrhagic strokes, we have what is known as a Guglielmi detachable coils. And this is when, if this is, so if this were a blood vessel and we have an aneurysm right there, an outpouching, and what they do with these detachable coils is that they put something over here in order to prevent it from bursting, okay? So this is what's called a Guglielmi detachable coil. They use platinum coils, and the purpose, again, is to occlude or to prevent the rupture of an aneurysm. And then, of course, we could have an aneurysm clipping. In an aneurysm clipping, it's similar to that coil that I told you about, but let's say that this was the aneurysm. What we could do is to clip this so that there's no more possibility of blood going in there and causing it to rupture, okay? They may also be used for ruptured aneurysms in order to close off that area. And then decompressive craniotomy, this is when we remove part of the skull so that we can vent off the excessive pressure that is going to be collected in the skull. All right, so those are the surgical managements. Additional management of patients who have had a stroke might include also the use of a ventilator. So patients might have to be intubated. Usually they're intubated because they usually have a low Glasgow coma scale. And also it's going to be important, particularly if the patient has an increased intracranial pressure. Now, one thing that we need to talk about is permissive hypertension. And I think I talked about that yesterday, that in patients who have had a stroke, we allow for higher blood pressures. And the reason for that is to maintain tissue perfusion. And I think I illustrated that yesterday. If this is a brain tissue and this is a blood vessel, normally, it would be something like this. The blood vessels will not be occluded. But if the brain is inflamed, what's going to happen? It's going to encompass the area where the blood vessel is located. And therefore, there's going to be narrowing of the blood vessels. You need higher pressures to perfuse this area. And that is the reason why in patients that have strokes or brain injury, we allow their blood pressure to be high and we treat them once it goes beyond 220 systolic or 120 diastolic. It is going to be different in patients who have received TPA, in that we don't allow their blood pressure to go higher than 185 systolic and 110 diastolic. So I hope you understand why we allow those patients to have higher blood pressure. Seizures are going to be a common complication of brain injury, and therefore seizure precautions has got to be always be instituted, and continuous monitoring of the neurological status is going to be imperative. And we also need to assess for the need for assistive devices. So I'm going to talk about assistive devices in a little bit. So let's go to the most important things over here, which are the nursing management. Nursing care has a very, very significant impact on how patients recover. So there are several nursing interventions that has to be undertaken. Number one, positioning. And this is going to be important. How do we, or what is the goal of positioning? The goal of positioning is to prevent contractures. So position to prevent contractures. Now, I'm sure that you have seen patients who have had a stroke, and sometimes as a result of poor intervention by nurses during the recovery phase, they're going to have contractures. And this is going to be something that is emphasized in NCLEX. You need to make sure that you prevent contractures from happening. So how or what are the interventions that are going to be included to prevent contractures? Well, first of all, prevent flexion. So sometimes what happens is that the individual is going to have flexion contractures, and in order to prevent this, we always have to use a splint to maintain the anatomical position of the patient. The other complication is prevent adduction. To adduct is to go towards the body. So if this is the patient, the tendency is this arm, which would be affected, would go towards the body. So this is adduction. So how do we prevent adduction from happening? This is very important, and this is very common in NCLEX. We want to put the affected shoulder with a pillow placed in the axilla. So pillow in the axilla. In the affected arm, okay? So we want to prevent adduction. And then the other thing is, of course, to prevent edema. And how do we prevent edema? We want to make sure that we elevate the affected arm to prevent the edema and fibrosis. Because if you don't move your arm, what's going to happen is that you're going to have an edematous arm. And therefore, you want to make sure that you elevate that arm. And then, of course, we're going to prevent venous stasis. And of course, prevention of venous stasis includes many interventions. And among those interventions is exercise. It is helpful in preventing venous stasis, which may predispose the patient to thrombosis and pulmonary emboli. You could also use pressure stockings like TED stockings, as well as your SCDs or your sequential compression devices in order to prevent venous stasis. And then, of course, we want to make sure that we manage sensory difficulties. So, for example, if a patient has homonymous hemianopsia and they're blind on the right side, always make sure that you approach them from the good side or the good vision of that patient. So if they have right hemianopsia, you would have to approach them on the left side. Okay, so make sure that you always approach a patient with a decreased field of vision on the side where the visual perception is intact or not affected. And then, of course, we want to make sure that we are going to encourage self-care as much as possible. Remember, these patients might have hemiplegia, but they also have strength in the other arm. So we want to utilize that as much as possible. All right, could you answer these? Okay, so the patient has left-sided paralysis. All right, so that's a consideration, left-sided paralysis. The nursing assistant is doing range of motion exercises to the left extremities during the bed bath. This certainly is going to be okay. All right, we're looking for something that the nursing assistant did incorrectly. Elevating the foot of the bed to reduce edema. As I have said earlier, one of the nursing interventions that we need to do is to make sure that we prevent edema from happening by raising the areas that are going to be dependent. So elevating the foot of the bed, for example, or elevating the affected arm on pillows is going to be something that accomplishes that. Pulling up the client under the left shoulder when getting out of bed to a chair, under the left shoulder. This is going to be something that would cause dislocation and therefore is going to be dangerous. One other thing that I told you was patients usually adduct, so they're going to have adduct contractures. Not only is going to be the affected arm or leg that's going to adduct, but also the shoulders. And so that's going to be a challenge to make sure that we prevent that. And that's why we put pillows on the axilla in order to prevent that from happening. And on the other, the additional thing that we must never do is to pull patients by the arm, by the shoulder. We should always use a lifting sheet in order to reposition the patient. And also, when we're getting them out of bed to a chair, we're going to have to be very cautious that we do not dislocate their shoulder on the affected side. Okay? And lastly, letter D, putting high-top tennis shoes on the client after bathing. This prevents foot drop. And so you might have noticed, or I don't know if you've ever been to a neuro floor, but usually when we have neurological patients who are not able to move very well or have paralysis as one of the problems, we usually apply tennis shoes in order for them to prevent them from having foot drops. So the one that is going to be concerning over here is letter C. Okay. All right, very good. So hemianopia would be blindness in one side of the eye. So in order to compensate for that, you ask the patient to frequently scan the room so that they're not going or they're going to compensate for that blind area. So letter C is the correct response. All right, so what other nursing management is going to be important in these patients? Well, nutrition, nutrition, nutrition. It is always important that we have to make sure that we assist the patient in maintaining their nutritional state, particularly observing the patient for paroxysms of coughing, or sometimes they might have dribbling of the food or pulling of one side in the mouth. So whenever there is going to be weakness on one side, remember that food might be retained in that area and therefore could be cause of aspiration. So we always inspect the area of the mouth that is the weakest, where the droop is. All right. We also want to make sure that a speech therapist has got to evaluate the patient for gag reflexes. And it might be necessary to assist in teaching alternate swallowing techniques. And these are some interventions that the speech therapist can help you with. Okay, so including choosing foods that are easier to swallow. Now, contrary to what people think, the most difficult thing to swallow is liquids because it requires more muscles to control the entry, the safe entry of liquids. And that is why in patients who have dysphagia or difficulty in swallowing, we usually thicken the liquids. So we provide thicker liquids, or you puree the diet as might be necessary. And then, of course, we want to make sure that the patient sits upright, preferably on a chair when eating and drinking. And those are important considerations. Very good. Okay. So the answers are actually C and D. Ask questions that require a simple response. And the other one is discourage the patient, a communication board. All right. So when we have a patient with expressive aphasia, these patients can understand the spoken words, but they cannot respond effectively or at all. And the one thing that irritates me with nurses sometimes, whenever they have patients with expressive aphasia, is they're shouting at this patient like they don't understand that the problem is not in hearing, but actually in responding is what the problem is. So therefore, be patient, let the patient speak as much as possible, as direct and simple questions that require a simple response. And of course, communicating with a dry eraser board or communication board are going to be very, very good interventions for these patients. Okay. We should never fill in the words for what they can't say, or you have to repeat questions in order for you to reestablish the link, even though they're not being able to respond. The problem is that they cannot enunciate or move their muscles to speak. And that is what expressive aphasia is all about. So, which leads us then to improving communication. So, what are some of the interventions that improves communication? Well, we want to make sure that we make the atmosphere conducive to communication. So, what do I mean by that? Well, a lot of times there might be a television going on, a program, and you're trying to talk to the patient. Well, obviously, this is not going to be an ideal or a conducive environment for communication. And the other thing is to be consistent in schedule as well as routines and repetitions. So usually when we have stroke patients, we have a written schedule that might help the patient remember things. And this is something that the thing right here that is going to be a very, very valuable tool, which is a communication board. And then, of course, we want to make sure that we give them simple instructions, which leads us now to the types of aphasia. So whenever we have a stroke in the territory of the middle cerebral artery, the MCA, this is the most common aphasia-producing stroke. And this is going to be something that nurses have to be dealing with. So remember that the middle cerebral artery feeds blood to the language centers. And therefore, whenever you have a pathology in the middle cerebral artery, it's going to cause aphasia. So there are many types of aphasia, and they range in severity. And the aphasia could be, of course, the most common types are Broca's or non-fluent aphasia. And in a Broca's aphasia, this is referred to as an expressive aphasia. So the patient understands what you are telling them, but they cannot respond. Now, in Wernicke's aphasia, what happens is that the patient does not comprehend the speech, and therefore they might be talking, but it doesn't make any sense. Okay, so that's the difference between Wernicke's and Broca's aphasia. And then there's something called anomic aphasia. Anomic aphasia is a type of aphasia that is less severe, and usually this involves a difficulty or a struggle to use the correct name for objects or events. So that's anomic aphasia. And the last type of aphasia is global aphasia. And whenever we have a global aphasia, this is a severe deficit, and there's going to be little or no ability to speak, to understand speech, to read, or to write. Okay? So in anomic aphasia, there's just a struggle. It's mild. Global aphasia is going to be the type wherein you're going to have no or little ability to speak or to understand speech. So what are some of the interventions as far as aphasia is concerned? Well, here, speak in short, simple sentences, allow plenty of time for a response, talk with him or her, not for him or her, which means to say we're not going to fill in the blanks for them. We need to remove distractions, try writing, gesturing, pictures, and communication tools like iPad, and repeat back what you think he or she is saying. Take your time. Remember, it may take a while to get the words out. Let people know what works best for you, and use assistive devices. Getting frustrated is okay. These are some of the things that you can tell the person that has aphasia. In addition to that, we have specific interventions for the different kinds of aphasia. For receptive aphasia, remember, this is Wernicke's aphasia, and they're unable to comprehend the speech. So because they're unable to comprehend speech, we want to make sure that we use short phrases. We could use gestures or point while giving a command in order to enhance the communication with the patient. And be patient and not expect a fast response, and obviously remove distractions. For expressive aphasia, which is Broca's aphasia, remember that the patient understands the speech, but they cannot talk, or they cannot respond back with a speech. So the intervention is be patient and let them speak as much as possible. Be direct and simple when asking questions. Maybe you can give them options. Do you want to drink Coke, Sprite, juice, or whatever will be better, rather than asking them, do you want something to drink? Okay, so give them options is going to be a very good communication tool. And then, of course, the use of a communication board via a dry erase board or even an iPad. So those are the nursing managements of patients with aphasia. Well, how about the sensory difficulties that patients are going to experience? Well, we always want to make sure that we approach a patient with a decreased field of vision on the side where the vision is intact. So place all visual stimuli on this side. We might have to reposition the bed, for example. Like, for example, if you want them to be looking at the window, you want to make sure that their good vision is towards the window. Teach the patient to turn and look in the direction of the defective visual field to compensate for the loss. Increase natural or artificial lighting in the room. If the patient wears eyeglasses, you need to make sure that they're wearing them to improve vision. And then, of course, remind patient with hemianopsia of the other side of the body. Now, patients who have hemianopsia forget that they have another side. And therefore, this is the reason why we want to remind them that there is an existence of the other side. So place the extremities so that the patient can see those extremities, so that they know that they have a half, another half of their body. All right, so the other thing that is going to occur might be hemianopsia. And of course, this is one hemianopsia. Over here, this is on the same side. This is what's called homonymous hemianopsia, the same half of each visual field. So these are the different types of hemianopsia. As I told you, it could be the superior or the inferior parts, or it could be different areas. So whenever you see anopia, hemianopia, that means to say that there's going to be loss of vision in one half of the visual field. All right, so what are some of the interventions for hemianopia in general? Well, when they're reading, reading can be challenging for patients with hemianopia, but you could assist them by using a dark ruler to where the sentences are. So, this dark ruler or a straight piece of cardboard paper uh, will be helpful, and they can put it at the beginning or the end of the lines to clearly mark where each line begins or ends. And they also say that reading at a 45 to 90-degree angle usually can compensate for the hemianopia. The other thing is that as far as mobility is concerned, we want to make sure that the patient scans the environment by using the head to be part of the eye. In other words, by scanning, you're going to increase, therefore, the ability to see what is in the environment. And of course, when walking with somebody, the patient should, well, the one that's assisting the patient should be on the side with the visual loss. And of course, the use of a cane is also going to be very helpful. In general, always put things that are needed at the side of vision. And of course, teaching the patient to ask people to be on the side of their good vision. And because sometimes they might not see the other side of the plate, so when they eat, the half of the plate is eaten, but the other half is going to be left uneaten. And so, in order to prevent this from happening, we want to ask the patient to rotate the plate. So, if this is the plate of food, for example, this half might not be eaten. And so, therefore, we need to teach the patient to rotate the plate when eating so that they will see the whole content of that plate. And then, of course, support groups are going to be very important. Okay, so there are keywords over here that we need to underscore. Acute recovery phase. So, which means to say that the patient was just in the ICU. So, what are some of your priorities? Well, deep vein prophylaxis is going to be one of them. You remember, we need to put sequential compression devices or TED stockings. Fall prevention, particularly in patients who have right hemispheric stroke. And of course, swallowing precautions, because again, if you have hemiparesis or hemiplegia, it's most likely that you will also have dysphagia, and therefore the risk of aspiration is going to be important. Now, these ones, D and E, could be done later on, and the later part of the rehabilitation, but A, B, and C are the important ones during the post-acute phase. Very good. Okay. So uh, the correct answer here is letter B. Okay. So what is this letter C? The patient doesn't recognize a television or a pencil. This is what is called agnosia. Um, okay. So the last part is are the teaching points that you have to include in your plan of care for patients who have had a stroke, and they include resuming self-care as early as possible. So we want to make sure that they do to themselves what they can do as much as possible. So this would include providing, of course, assistive devices as indicated so that they can, of course, do that. And so having an occupational therapist make a home assessment and recommendations to help the patient become more independent might be included in the nursing care plan. Speech therapy, as we had already mentioned, in order to assist with swallowing, as well as, of course, regaining the ability to speak. Now, depression is going to be a major problem, and therefore, whenever this occurs, we encourage the family to report that to the physician so that antidepressant therapy or interventions could be initiated. And of course, it is important to encourage the family to join support groups because this is going to help them with positive reinforcements. So that is the end of my lecture for today. And I hope that you all were able to gather a lot of information about the nursing intervention of patients with stroke. So tomorrow will be our last day, and we will continue with neurological conditions that are chronic in nature. So you all have a good evening. Thank you, Jeneline and Annie, for attending again. You're the only two that have been consistent. So I welcome you and hope to see you tomorrow. Have a great evening, okay? Bye-bye.